Welcome to the Nclex Crash Course. In this series, we'll cover topics like pharmacology, medical surgical nursing, pediatric nursing, obstetric and gynecological nursing, and psychiatric nursing. Don't forget to subscribe for more valuable Nclex Crash Course episodes.
In this patient, what is the nursing care that we will provide? So let's start with the assessment. So what things we are going to assess? So we have to assess for the history of heartburn, regurgitation, and dysphagia. All the things we have to ask. Baseline weight to determine need for weight loss. Dietary and medication history to determine contributing factors. So these things are also very important to know, because there might be some medication that will be increasing the acidity in the gut, and some foods like fatty foods that are contributing in excess acid in the stomach. And we have to obtain the weight so that we can make the dietary chart for the client if the client needs the weight loss. And of course, the history of heartburn, because that is the major symptom, regurgitation information, and about the difficulty in swallowing. So all these things we have to assess. Now, what we are going to plan and implement in these clients. So first is teaching dietary guideline. This is the most important thing in the GERD. It is seen that by the dietary management only, major part of the GERD disease can be reversed back. So we have to guide the patient to eat small, frequent meals to avoid gastric distension. More food you eat, more acid is released. Therefore, always eat small and frequent meals to avoid gastric distension. Limit fatty food. Fatty food leads to increased acidic content in the stomach, which delay the gastric emptying. So fatty foods remains in the stomach for a long time. That leads to increase in the acidity of the gut. Therefore, this should be limited. Avoid foods that decrease lower esophageal pressure. For example, alcohol, peppermints, caffeine, and chocolate. So all these food decrease the lower intestinal pressure. They have vasodilation properties. Therefore, they leads to the decreased pressure in the lower esophageal sphincter. So these food should be avoided. Avoid eating or drinking 2 to 3 hours before bedtime. Avoid overeating. So it is seen that after having meal, you have to keep sitting for at least 2 to 3 hours, or you have to walk after eating, so that all the stomach content settle down and it does not regurgitate back to the esophagus. So if you suddenly lie down on the bed after eating, so due to poor gravity, the content may come back in the esophagus. And avoid overeating. Overeating can also lead to reflux back of the content. Chew gum, because it stimulates production of bicarbonate containing saliva, which neutralizes acid. So this is also important. When we chew gum, so the saliva is created in a large amount, and saliva contains bicarbonate ions which neutralize the acid. Therefore, these things we can plan for the patient. Teach to maintain desirable body weight. Avoid tight-fitting clothing and activities that increase intra-abdominal pressure. So when the intra-abdominal pressure will increase, it can lead to regurgitation of the food back in the esophagus. Therefore, tight-fitting clothes should be avoided, and you have to maintain desirable body weight. Okay, that is also very important in these patients. Support smoking cessation efforts. So smoking is bad in this condition. It aggravates the symptoms of GERD because it contains vasodilation properties. That's why. Elevate head of the bed. Use extra pillows. Avoid exercising or lying down after the meals. So this is the same as I have mentioned, that it is very important to maintain the upright position after meal so that the content do not go back in the esophagus. Provide care after endoscopic therapy, that is Stretta procedure. Ensure patent airway. Elevate head of the bed 45 degrees. Monitor the vital signs for complication and assess the oxygen level in the patient. So all these are the interventions that should be done. Next is saturation. So to see the saturation is very important. Suction secretion should be assessed. Report pain more than 5 or on the scale of 0 to 10. So if the pain level is more than 5, so the symptom of pain can indicate perforation. So because this may indicate perforation, therefore pain should be reported. Provide discharge instructions. So we have to provide the discharge instructions. For example, avoid non-steroidal anti-inflammatory drugs for 10 days. NSAIDs should be avoided for the 10 days. Now, why NSAIDs should be avoided? Now, in some studies, it has been seen that NSAIDs increase the acidic reflux in the stomach. Therefore, it can lead to reverse back of the acid in the esophagus. Therefore, these are contraindicated in the patient having GERD. So this we have to always remember that NSAIDs are totally contraindicated for at least 10 days in the GERD patient. Consume soft diet for 2 weeks, crush all pills, and report fever, nausea, and vomiting, dysphagia, abdominal discomfort, chest pain, bleeding, and shortness of breath. So all these symptoms should be, or side effects should be, told so that we can assess for the complications. Next is evaluation or outcome. So what is the evaluation we will do after all the interventions? So patient reports reduced episode of heartburn. If patient reports reduced episodes of heartburn, it means that the nursing interventions were successful. Maintains desirable body weight. So patient, if maintains desirable body weight, it means that the dietary pattern is good and there is decrease in the acidic reflux. Therefore, the nursing care is successful. So this was all about the gastroesophageal reflux disease, in which we saw that what is GERD, what it is actually, and why this occurs, and what this can lead to. So this can lead to Barrett esophagus and can progress into the esophageal cancer. Then we saw that what are the symptoms, that is subjective and objective data. Then what are the interventions applied? They are in pharmacological management form and dietary management form, and weight reduction planning. And we can see here the nursing care that we are going to provide to client having GERD, that is assessment and planning and then evaluation. So this was all about GERD. Now let's see cancer of esophagus. So what is the cancer of esophagus? So as the word says, there will be formation of tumor or metastasis in the esophagus. So what is the etiology and pathophysiology? So history of alcohol abuse, ingestion of hot, spicy food, smoking, GERD, or Barrett esophagus, that is esophageal damage from acid reflux. So when there is a repeated history, repeated exposure of the acid content in the esophagus, so that will lead to damage to the cells of esophagus, and that can lead to the cancer. So patient having history of alcohol abuse, ingestion of hot, spicy foods, that increase the acid level in the stomach and can lead to reflux of acid. Barrett esophagus, as we have discussed, due to repeated exposure of acid in the esophagus will damage the mucosa, that is Barrett esophagus. So all these things lead to the cancer of esophagus. Additional risk factors are old age. So in the old age, the sphincter become, impaired, so that can lead to the GERD. In males, it is commonly seen, and African Americans, it is commonly seen. Most common in middle and lower third of the esophagus. So it is commonly seen in the lower part and the middle part of the esophagus. Now moving on to the clinical findings. So what we are going to see in these patients. So reported by the patient is subjective data, in which the patient will tell the not ability or difficulty in swallowing, that is dysphagia. So patient will report difficulty in swallowing. Second is substernal burning pain. So just beneath the sternum, the burning pain will be felt, and it will be all due to the increased acid in the esophagus, particularly after hot fluids. So hot fluids or hot substance will enhance the acidic burning in the esophagus. Weight loss will be seen. Due to this burning, due to this dysphagia, patient will have loss of appetite, and due to that, the weight loss will be seen. Indigestion will be seen, in heartburn, that is pyrosis, will be seen in the patient. Objective data. In objective data, regurgitation we will see. Hoarseness of voice, cough, esophagogastroduodenoscopy with biopsy and brushing demonstrate malignant cells, barium swallow indicates mass. So when we are going to diagnose, then in diagnosis, if esophagogastroduodenoscopy, so this is the endoscopy of esophagus and stomach in which the malignant cells will be seen. And when the barium is swallowed by the patient, so the mass will be differentiated in the esophagus. That will confirm that patient has esophageal cancer. Moving on to the therapeutic interventions. So what are the interventions that we will apply on the client? First is surgical removal of esophagus is the treatment of choice. So if there is cancer in the esophagus, so surgical removal is the treatment of choice. In this esophagogastrostomy. So what is esophagogastrostomy? In this resection of portion of esophagus in which stomach may be brought up to the remaining end of the esophagus. So for example, this is the esophagus and this is the stomach. So there will be resectioning, that is removal of the part that contains the tumor. Resection will be done and these two parts will be jointed. So resection of portion of esophagus in which stomach may be brought up to the remaining end of the esophagus. So this portion of the stomach will be joined to the remaining portion of the esophagus. Second is esophagectomy. So what is esophagectomy? It is removal of part of all of the esophagus. In this, all of the esophagus will be removed, which is replaced by a Dacron graft. So Dacron graft will be placed in place of the esophagus or portion of colon. So colon will be used as an artificial, or we can say it will be used as a replacement for the esophagus. That is colon interposition. So this is the important thing we have to remember here. Next is gastrostomy. In gastrostomy, the opening directly into the stomach in which a feeding tube is usually inserted to bypass esophagus. So esophagus will be removed and the tube will be administered, which will directly open into the stomach. Radiation or chemotherapy may be used before or instead of surgery as a palliative measure. So sometimes when surgery is not indicated or applicable, so radiation or chemotherapy will be used. In these patients, total parenteral nutrition or enteral feeding tubes will be given because there is esophageal cancer. So there will be contraindication of the intake of food by the mouth. So in these patients, the nasal route or IV route will be chosen for feeding. So in TPN, IV route should be used, and in enteral tube feeding, nasal route is obtained for feeding. Photodynamic therapy for palliative treatment. So in palliative treatment, palliative means treatment in the end stage. So photodynamic therapy is used. Porphymer sodium, which is photofrine, is injected and several days later, a fiber optic probe in esophagus activates absorbed drugs in cancer cells, shrinking them. So basically, this is a procedure in which porphymer sodium is injected, and after many days, a fiber optic probe in the esophagus activates the absorbed drug in cancer cells and shrink all the cancer cells. So this is the latest thing that we will see in the client having esophageal cancer. Laser therapy. In laser therapy, a narrow beam of intense light will be used to kill the cancer cells. Electrocoagulation. In electrocoagulation, electric current will be used to kill the cancer cells. So these are the various procedures which will target on the cancer cells directly, so that the removal of the esophageal will be not needed. In that case, this is done. Moving on to the nursing care of clients with cancer of esophagus. So what is the care that we are going to provide? So starting with assessment, we have to take history of nutritional status and weight loss. We have to check if patient has weight loss. That will indicate the esophageal cancer. Presence of pain and dysphagia. So these are the two main symptoms that we have to assess for their presence. History of foul breath, eructation, nausea and vomiting. So if patient has a history of foul breath, eructation means burp, nausea and vomiting. So all these indicate that there is something wrong in the esophagus and we have to further confirm the diagnosis. Moving on to the planning and implementation. So we have to observe for respiratory distress. This is the first goal that should be established. Caused by pressure of tumor on the trachea. So as we know that esophagus and trachea lie parallelly to each other. Therefore, if there is tumor in the esophagus, so this can press the trachea and this can lead to, obstruction in the breathing. Therefore, we have to observe the patient for respiratory distress, place the patient in semi-fowler position or high fowler position to facilitate respirations. This is the first and most important thing of the nursing care. Second is monitor vital signs, especially respirations. So the baseline data should be obtained in the patients so to check any kind of infection or any kind of vital changes in the body. Third thing is provide oral care because dysphagia may result in accumulation of saliva in the mouth. As the patient has difficulty in swallowing, so all that saliva accumulation in the mouth can lead to foul smell. Therefore, oral care should be provided. Maintain nutritional status by providing TPN. So total parenteral nutrition is the method in which the food that is not ingested by the mouth is given by the intravenous route, so to maintain the nutritional status. And tube feeding can be done. High protein liquids and vitamin and mineral replacements as ordered. We have to suction the oral secretions if necessary. So if patient is having dysphagia, so we have to suction that, saliva that is accumulated in the mouth. Next thing is evaluation. So what we are going to expect after all the nursing care, that patient maintains the airway, patient maintains the nutritional status. So in the case of esophageal cancer, our main goal is to establish the nutritional status so that patient can live a healthy and, comfort life. And the maintenance of airway should be there. So this was all about the esophageal cancer. I hope that this was clear. Now let's move on to the next disease, that is Hetal hernia. So what is Hetal hernia? Portion of stomach protruding through hiatus, that is opening in the diaphragm into thoracic cavity. So basically, when there is protrusion of the stomach through the hiatus, what is hiatus? It is the opening in the diaphragm into the thoracic cavity. So we know that when we can see the diagram of our respiratory system. This is our esophagus and this is our stomach. And if you make a good diagram, so this is the esophagus and this is the stomach and this is the diaphragm. So there is a hiatal opening in the diaphragm from which stomach content protrude out in the thoracic cavity. So this is the hiatal hernia. It is caused by congenital weakness of the diaphragm or from injury, pregnancy, or obesity. So these can be the causes of the hiatal hernia. There may be weakness of the diaphragm. Due to that, there is protrusion of the stomach content due to the, less pressure. Function of cardiac sphincter is lost. Gastric juice enter esophagus causing inflammation. So cardiac sphincter is between the esophagus and the upper part of the stomach. So that function is lost and gastric juices enter into the esophagus. That leads to inflammation. Now moving on to the clinical findings. So in subjective data, substernal burning pain will be seen or fullness after eating, dyspepsia in recumbent position, nocturnal dyspnea. So all these symptoms will be seen in the patients having hiatal hernia. So due to protrusion of the content of the stomach from the diaphragm, there will be difficulty in breathing due to pressure on the trachea. And also because there is weakness of the cardiac sphincter, so all that content that revert back in the esophagus will lead to burning or fullness after eating or dyspepsia. In objective data, we will do the barium swallow and upper GI series and endoscopy. This will show that there is protrusion of stomach through the diaphragm and regurgitation will be seen. So all these are the clinical findings. So what will the therapeutic interventions for this patient? So we will advise the patient to have small, frequent and bland feedings, because our goal is to reduce the acidic content. Our goal is to reduce the, all these symptoms, the severity of the symptoms should be reduced. We have to tell the patient to avoid overeating, caffeine, smoking, alcohol. So these therapeutic interventions are same as those of the GERD and cancer of esophagus. We have to tell the client to wear loose fitting clothing around the torso so that there is decreased pressure in the stomach, which will prevent in the reflux of acid in the esophagus. Pharmacological therapy will be given and dietary management will be given. So the therapeutic interventions will be same as that are given in the GERD. So as we have seen in the GERD, there are many antacids, protein pump inhibitors given to the client. So all these things will be given to the client as same. So as we can see here that in pharmacological treatment, histamine receptor antagonist, antacids, PPI, and cholinergics, pro-motility drugs will be given. So this will be same in the hiatal hernia. So our goal is to reduce the acidic level in the gut. So this will be our goal. And surgical repair can be done. That is done very infrequently. So the revert back of the stomach content will be done, but it is done rarely. Now next is the peptic ulcer disease. So what is the peptic ulcer disease? Now peptic here means the stomach, and ulcer is the erosion of the mucosal membrane. So ulceration of the GI mucosa and underlying tissue caused by gastric secretions that have low pH, which means due to high amount of acid in the gut, the mucosa will be damaged and that will lead to ulceration of the GI mucosa. So this is called peptic ulcer disease. Now, what are the causes of peptic ulcer disease? So all the conditions that increase secretions of HCl by gastric mucosa or that decrease tissue resistance to acid. So there may be two causes, that there is increased HCl production and second, there is decreased tissue resistance to the acid. So all these two causes will lead to peptic ulcer disease. Infection of gastric and duodenal mucosa by Campylobacter pylori or H. pylori is the cause of peptic ulcer disease. So if we talk about peptic ulcer disease, H. pylori is a very common, bacteria that is the reason of peptic ulcer. Zollinger-Ellison syndrome. This is very important. What is Zollinger-Ellison syndrome? Tumor secreting gastrin that stimulates production of excessive HCl. So in Zollinger-Ellison syndrome, there is a tumor that secretes gastrin and that leads to excessive production of HCl. So this is also seen after the complication of peptic ulcer. Drugs that decrease tissue resistance. So all these drugs, for example, aspirin, steroids, NSAIDs, that decrease the tissue resistance and increase the acid level will lead to the peptic ulcer disease. And smoking. So smoking and NSAIDs and the tumors that increase the HCl, H. pylori bacteria, all these are the causes of the peptic ulcer disease. Peptic ulcer disease may be present in esophagus, stomach, pyloric portion, most common site. So if we talk about the most common site of the peptic ulcer disease, so that is the pyloric portion or duodenum. Complications include pyloric or duodenal obstruction, hemorrhage, iron depletion, and perforation. So due to peptic ulcers, there will be decrease in the absorption of food, which can lead to nutritional deficiency, for example, iron depletion and obstruction, and hemorrhage, that is bleeding due to high degree of ulcers and perforation of the mucosa. So this is about the peptic ulcer disease. Now moving on to the clinical findings. So talking about subjective data, so as like the other disorders of GI, heartburn will be reported. So in all the diseases where acid increase is the reason, so heartburn or pyrosis will be observed. Nausea, gnawing or burning epigastric pain 1 to 2 hours after eating, that is gastric. So there is a difference between gastric and duodenal ulcer that we have to remember. So in gastric ulcer, the epigastric pain or burning occur after 1 to 2 hours of eating. After 1 to 2 hour of meal, the pain occurs. But in duodenal ulcers, after 2 to 4 hours, the burning occur. So gnawing or burning epigastric pain 1 to 2 hours after eating or 2 to 4 hours after eating in duodenal ulcer. Pain relieved by food or antacids in duodenal. So we can see here that in duodenal ulcer, when stomach is empty, so when the stomach is empty, the acid that is present in the stomach will lead to the burning sensation. So in duodenal ulcer, the symptoms occur due to empty stomach, whereas in gastric ulcer, the symptoms occur due to eating food. So this is a major difference between the gastric and duodenal ulcer. Gastric due to food and duodenal burn due to empty. So the pain or the burning will be relieved by the food or antacid in the duodenal ulcer. This we have to remember. Objective data. So we have to know about the history of gastritis. We have to know if bleeding occurs, indications of anemia, tarry stools, that is melena. So we have to see if bleeding is occurring, because in the case of peptic ulcer, due to perforation, bleeding can occur through the, which can be observed by the tarry stools, that is melena, blood in the stool. Vomitus, the color of coffee, because peptic ulcer disease occur in the stomach. So if the vomiting occurs, so the blood will be old blood, not the fresh blood. Whereas in stools, the blood will be fresh, therefore the melena will be seen. So old vomitus, that is color of coffee, blood will be seen, or port wine color. Low hemoglobin and hematocrit level. So due to ulcers, there can be bleeding, internal bleeding, that will lead to anemia and low hemoglobin level in the body. H. pylori serum antibodies via urea breath test or via biopsy during the EGD. So these things we have to remember. These are very important points, that in patient having peptic ulcer disease, urea breath test is done. So when urea breath test is done, urea is advised to ingest by the patient, and when the nitrogen paper is applied, so the HCl will change the color of that paper. That will indicate the acidic level in the gut. And antibodies can be detected and biopsy can be done using the EGD. So this is the objective data that will confirm the peptic ulcer disease. Now, what are the therapeutic interventions that we can use for these patients? Restriction of irritating substances, for example, nicotine, caffeine, alcohol, spices, gas-producing foods, NSAIDs. These all things should be avoided because they increase the HCl level or decrease the tissue resistance for acid. Antibiotic therapy if microorganism is identified. Okay, so if there is H. pylori, so tetracycline, that is samicin, metronidazole, that is flagyl, and bismuth, that is helijack, will be recommended. Histamine H2 receptor antagonist or proton pump inhibitors to limit gastric secretions, antacids to reduce acidity, protectants, for example, sucralfate, that is carafate. These all will be used to decrease the acidity level in the gut. So, peptic ulcer disease, we have to remember, is due to the acidity. Therefore, the antacids, the PPIs, are very, very important here. Sedatives, tranquilizers, anticholinergics, and analgesics for pain and restlessness. So, if there is a lot of pain and restlessness, so sedative tranquilizers can be given. Antiemetic for nausea and vomiting can be given. Vasoconstrictor to control bleeding can be given. Blood transfusion should be done if the hemorrhage occurs, if there is anemia and low hematocrit. Nasogastric tube for decompression can be applied. So if there is a lot of acidic level in the gut, so the removal of that acid can be done by the decompression. Installation of vasoconstrictors or saline lavage when hemorrhage occurs. So all these things can be done. So in saline lavage, if there is a lot of bleeding in the gut, so saline lavage, that is remove the content by the mouth, is done. Same in the decompression, removal of the HCl from the mouth is done. In surgical interventions, these are rarely used because drug therapy usually is effective, used for life-threatening complications. For example, there is a lot of hemorrhage, perforation, obstruction. In that case, surgery will be used. EGD to treat area with electrocoagulation or heater probe therapy. So if there is electrocoagulation or heat probe therapy, so EGD will be done. Vagotomy, if there is a lot of HCl production, if nothing is working, so vagus nerve can be cut. Cutting of vagus nerve that innervates stomach to decrease the secretion of HCl. This is very important. So to decrease HCl level, there is cutting of the vagus nerve in the stomach. Billroth 1 procedure. So what is Billroth 1? In Billroth 1, removal of lower portion of stomach and attachment of the remaining portion to duodenum is done to treat carcinoma. So if there is complication and cancer occurs and a lot of perforation occur, so Billroth 1 can be done. In Billroth 1, there is gastroduodenostomy. It means that the lower portion of stomach will be removed and the upper portion of stomach and the duodenum will be attached to each other. In Billroth 2, the antrum and distal portion of stomach will be removed and it is, resection with the jejunum. So this is gastrojejunostomy. Billroth 1 is gastroduodenostomy and Billroth 2 is gastrojejunostomy. The difference is that in both, the lower portion or upper portion is removed and the remaining portion is attached to duodenum and respectively to the jejunum. Entrectomy. In entrectomy, the antral portion of stomach will be removed. In gastrectomy, 60 to 80% of the stomach will be removed. So all these things will be done when the medical treatment will fail and the perforation will be more, the hemorrhage will be more. So in that case, these things will be done. Now, what are the common complications of partial or total gastric resection? So as we have seen, gastric resection means removal of 60 to 80% of the stomach. So what will the complications? So the most important is dumping syndrome. Now, what is dumping syndrome? The rapid passage of food from stomach to jejunum causes diaphoresis, faintness, and palpitations. So as we know that foods needs to process in the gut. But if there is removal of the stomach, so there will be a very fast passage of the food from stomach to directly to the jejunum. That leads to the diaphoresis, faintness, and palpitations due to sudden hypoglycemia. These clinical manifestations are related to hypertonic food, especially carbohydrates, that draws fluid from circulating blood into jejunum, decreases peripheral vascular resistance, visceral pooling of blood, and recreate reactive hypoglycemia. So we have to understand here that when we are ingesting food, so our brain takes time to adapt the sugar level. So when we are taking carbs in the body, and when we are taking especially the hypertonic food, so the fluid is drawn from the blood in the jejunum, and that fluid, when it is drawn from the blood in the jejunum, there is decrease in the peripheral vascular resistance, and that leads to the hypoglycemia. So that hypoglycemia can lead to faintness and palpitations. Hemorrhage is also a complication seen. Pneumonia can be also seen, and pernicious anemia can be seen in the patients having gastric resection. Now, what is the nursing care provided to the client having peptic ulcer disease? So, in assessment, characteristics of pain, for example, we have to differentiate between the duodenal and gastric ulcer. Therefore, we have to assess the characteristic of pain. If it occurs to the time when food is consumed, or if it occurs when the stomach is empty. So it all depends. So characteristics of pain in relationship to the types of food ingested, the time food is consumed, whether gnawing sensation is relieved by the food. So all these things we have to ask. Epigastric tenderness, guarding, and bowel sounds we have to assess. History of dietary pattern, food ingested, alcohol consumption, and food that exacerbate the symptoms. All these things we have to assess. In planning and implementation, administer and assess effects of sedatives, antacids, anticholinergics, H2 receptor antagonist, antibiotics, and dietary modifications. So, as per the physician's instructions, all the medication will be administered and the effects will be assessed. We have to encourage the dehydration to reduce anticholinergic side effects and dilute hydrochloric acid in the stomach. So this is also very important. To dilute the HCl in the stomach, the hydration should be encouraged. We have to provide teaching. So what teaching we have to provide? Eat small to medium-sized meal to help prevent gastric distension. Encourage between meal snacks to achieve adequate calorie intake. Avoid foods that increase gastric acid secretions or irritate gastric mucosa, for example, alcohol, caffeine containing foods, beverages, decaffeinated coffee, red or black pepper. Replace offended items with alternatives. Okay, for example, decaffeinated soft drinks and tea, seasonings such as thyme, basil, and sage. So, all these items should be replaced by the other alternatives. So, this was about the teachings. We have to tell to the patient to avoid food that cause distress. Varies for individuals, but common offenders are gas producers. Example, legumes, carbonated beverages, cruciferous vegetables. So all these things are common that are offenders and produces the gas. Eat meals in pleasant, relaxing surrounding to reduce acid secretions. Take calcium and iron supplements if prescribed, if medication increases the gastric pH. So these things we will tell. Refrain from administering drugs that increase the HCl, for example, NSAIDs, salicylides, steroids, and adrenocorticotropic hormone. So these medications which increase HCl level should be not given. Monitor for complications. We have to always monitor for the complications. This is very important in the view of the nursing care. We have to see gastric hemorrhage, perforation, and drug toxicity. Allow time to express concern. So this is also very important because stress is a very important or major factor in peptic ulcer disease. So stress leads to increase in the HCl production. Therefore, we have to provide time to allow to express concerns. Ventilation of feelings will help the patient to decrease the stress and will help in proper healing. So this was about the teachings. We have to provide post-operative care after gastric resection. We have to monitor vital signs, assess dressing for drainage. We have to maintain patent NG tube to suction, which help prevent the stress on suture line. Instill or irrigate NG tube as ordered. Monitor electrolytes. So these all are the nursing care that we have to provide to the patient. Then we have to observe and document the color and amount of NG drainage. We have to report excessive bleeding or bright red blood if it occurs after 12 hours. So after the surgery, it is our goal that the hemorrhage and bleeding should be stopped. But if there is a bleeding, then this is the complication that should be documented and reported. We have to encourage coughing, deep breathing, and changing position frequently to prevent pulmonary complications. We have to monitor the intake output, and we have to apply anti-embolism stockings or sequential compression device if ordered if patient is on the long-term bed. We have to encourage early ambulation and to prevent vascular complications. So when patient is on, is bedridden, so this is also very important to maintain the circulation in the body so that the deep vein thrombosis things do not occur. We have to instruct the client how to limit or prevent dumping syndrome. So we have studied about dumping syndrome when the food is directly going from the esophagus directly to the duodenum, and it is not laying in the stomach. So we have to tell the client to eat smaller meal at more frequent intervals, avoid high carbohydrate intake and concentrated sweets, consume liquids only between meals, assume a reclining position for 1 hour after eating, and antacids 1 hour before or 2 hours after the other medications. So all these things will be advised. What is the evaluation? What outcome we expect? States pain is reduced or relieved. So if patient says that there is no pain or reduced or relieved pain, so the care is successful. If patient identifies clinical findings of complications and need for immediate medical care and follows nutritionally sound diet, it means that nursing care has been successful. So this was all about this video. I hope that peptic ulcer disease, hiatal hernia, esophageal cancer, and other diseases were clear to you. If there is any doubt, let me know in the comment section. We will meet in the next video. Thank you.